Dr. Doug Jones is an American board-certified allergist and immunologist, long COVID and asthma specialist. Apart from his founding role in Immunity Group Australia, he's also the founder of Global Allergy Immune Network and has been a co-founder and president of FAST OIT, a global association and gathering place of allergists and physicians with a special interest in allergy. Welcome to our podcast, Doug.
Thank you. It's a pleasure, an honor to be a part of it.
For people who are not familiar with allergy as a subspecialty of medicine, the word allergist and immunologists put together can be somewhat confusing. So, are all allergists immunologists and vice versa? And what is the difference?
Yeah, it's a really good question. And it can be confusing for a lot of people. I think one thing that's consistent across the world, not just in the United States, but I think across the world, is when we go through our specialty training, we go through both allergy and kind of a clinical immunology training. And uh, the allergy piece focuses more on that allergies, whether it's food allergies or environmental allergies, drug allergies, um, all kinds of allergies. The immunology part can focus a lot on complex immune disorders like autoimmune disease, immune deficiencies, where your immune system doesn't work quite right. Um, Certain things like long COVID, which is an emerging thing over the last 5 years. Um, Maybe vaccine science, th those types of things where it involves more of the immune system, not just the allergies. If it were up to me, I would just call it all immunology because allergies are immune related. It all would fall under that umbrella. But nobody would know what an immunologist is. So.
Thank you. That really clarifies when people especially are confusing, not sure where to go,
Yeah.
and don't, sometimes people think maybe an immunologist is a person who looks at blood disorders because it's
Right.
connected to
That's
immunity.
that's a hematologist, but
Exactly.
um,
Yeah.
and certain specialists may specialize in more allergies and less immunology, and others may specialize in more immunology and less allergies. So you can get some that gravitate towards one versus the other, but we have training in all of it. I do all of it. Um, so yeah.
Amazing. I had the privilege as an observer to attend FAST OIT Congress in Dallas this June, and it is the premier gathering place of doctors who have a special interest in allergy and who want to either implement OIT SLIT in their practice or have already done it. And I've been approached by a lot of doctors from all over the world in the last couple of months asking me, what is the benefit of them coming to Dallas for this annual congress in June? Is it worth investing and what can they get out of it as practitioners who perhaps want to learn more? So, what would you say as co-founder of fastoit.org say to them?
First, let me define all of the acronyms that you just used because there may be certain people in the audience that don't know what FAST or OIT or SLIT are. So, FAST is a nonprofit organization, uh, stands for Food Allergy Support Team. And this was co-founded by me and two other allergists in the United States about 9 years ago. And we're dedicated to the education and research of food allergies, trying to implement the latest in uh, diagnostics and also best practices in treatment. Part of the treatment is OIT. The other acronyms you used was OIT or SLIT, and that stands for oral immunotherapy or sublingual immunotherapy. Oral just means it's taken orally, by mouth, swallowed. Sublingual immunotherapy means the therapy is given as kind of a drop under the tongue, sublingual. And immunotherapy just means it is a therapy that is modulating the immune system. So when we do oral immunotherapy or sublingual immunotherapy, we are actually changing the immune system. And that is different than some other types of treatments that are now approved in the United States. One is a biologic medicine called omalizumab or Xolair. That treatment is FDA approved for food allergy, but it does not change the immune system, does not alter it. So it is not actually an immunotherapy, but it is a food treatment that we talk about. So that's just kind of the basics of those terms. With FAST OIT, our annual congress that you mentioned, the reason somebody would want to go to that is because it is a congress unlike any other that I've ever seen. We are not sponsored by a pharmaceutical company or industry. We are self-funded. And so our agenda isn't beholden to anyone other than our members and our patients. And therefore, we can have very candid discussion. Um, we discuss topics that aren't discussed at any other Congress that I've ever seen. Even the largest meeting in the world for allergists is the American Academy of Allergy, Asthma, and Immunology, and they don't cover the topics that we cover, nor do they even approach the depth that we go over. So we have both breadth and depth to our discussions. We take people all the way from the beginning, even if they've never seen a patient for or treated a patient in food allergy, we give them the basics of how to identify the patients, what to go over with their consent forms, how to set up their staffing in their office, their scheduling. But then we transition all the way through very experienced allergists, and we have this wonderful blend of doctors and teams, not just doctors, but their teams are welcome to come too. We have this wonderful blend of new and experienced, and we really facilitate that dialogue and networking amongst them so that we have an open and free communication. I've never seen anything like that. So if people would say, why would we want to go? Why wouldn't you want to go? I mean, that's kind of the bigger question is why wouldn't you? This is a tremendous opportunity to be able to rub shoulders with whether you're new or experienced with your colleagues and be at the forefront, cutting edge science that's delivering groundbreaking and impactful treatments, life-saving treatments to our patients. And it's been one of the most rewarding things that I've ever been a part of in medicine. And especially nowadays where medicine is run by bureaucracy and sometimes uh, large healthcare systems or insurances or whatever, this really takes it to the grassroots effort and takes it back to doctor patient. And it's really a beautiful thing.
When you talk about modulating the immune system, for our lay audience, including myself, it reminds me of that phrase, how to train your dragon, how to train your immunity. Is it possible to train your dragon slash immunity? And what does it actually mean in practice?
Yeah, that's a great question. So yes, we are training the immune system. So we're taking it from, I always look at whenever you get symptoms of any kind, whether it's allergy or not, it's your body communicating. And that's how I always think about symptoms is what is the body currently communicating to me? And when somebody has an allergic reaction, that body's communicating that whatever they just came in contact with, it's posing a threat. And what we can do is retrain the immune system basically so that it doesn't, your immune system's interpreting that as a non-threat. And we're able to change uh, how that immune system functions literally at a DNA level. And it's such a beautiful part of reprogramming, retraining the immune system. And in fact, when you do immunotherapy, part of risk of developing allergies is a genetic predisposition. When we do immunotherapy, that person then will have, if that goes through it, will have less chance of passing those allergy genes to their children. So you're
That's
not
really,
only hurting that person, you can, affect generations down the line.
and that's an amazing opportunity for
Yeah.
everyone. Is there a window of age? Some people think if you do oral immunotherapy just for babies, it has a greater impact in that regard as well in the immunity retraining or memory cells. Or does it matter if you're 65, as your oldest patient was, over a decade ago in Utah? What is that age recommendation? Is there one to start with?
Yeah, children are often emphasized just because mainly statistics are out there. But in truth, you have a larger percentage of adults that have food allergy than children. But it's just that's where it's emphasized. You can do it in any age. I mean, I've done anywhere from uh 9 months of age all the way up, you mentioned, to my oldest patient, 65 years old. That was actually 10 years ago, so he's 75 now. Um, and the focus is on children, but wow, talk about impact in the 65-year-old, not only his life, but his wife's life, because she was the one that was doing a lot of the grocery shopping and vetting the restaurants. They traveled a lot, vetting the restaurants, and it affected her probably as much, if not more than him. So, yeah, it can absolutely make an impact no matter what age you are. Now, having said that, the sooner we can get going, the earlier in life we can get going, the better. And part of the reason I say the better is when we can start young children and we capture that immune system when it's naive, not fully matured, they take really well to the therapy. We tend to have less side effects, not only because we're able to capture and retrain that immune system early on, but when they're that young, they don't carry that psychosocial burden or anxiety that perhaps an adolescent would. And they have just less stress. They're more in control under their parents' eye. And so there's certain factors that do give an advantage to young children when we can get it started as early as possible. Um, but I would say if you're struggling with food allergy, no matter what age you are, um, look into it because it can be impactful and successful at all ages.
There's a huge debate at the moment amongst the medical community as well. What does true tolerance mean in the context of food allergy treatment, such as both oral immunotherapy and sublingual immunotherapy? But if we focus on OIT or oral immunotherapy, do you believe it's achievable for most patients, or is it a realistic aim? Because patients often don't know what their goal is. Often doctor would ask you, what is your goal? And they just know they don't want to have this food allergy. So how do we go back to that level and think ahead? Is it possible to achieve true tolerance of food?
Yes, it's absolutely achievable to get true tolerance to the food. And your point is well taken because part of the reason OIT took off, I think, this is my opinion, part of the reason OIT got popular prior to sublingual immunotherapy was because when we were pioneering this 10, 15 years ago, we all thought in our minds as doctors, well, everyone's going to want to just eat these foods and have it in their diet fully. And OIT allows you to do that. SLIT does not immediately. So SLIT, just to kind of give some differences, like with OIT, you absolutely can get tolerance and you can free eat without avoidance. And yes, there's hundreds of allergists that are able to do this, not just one, but hundreds that I know personally and have trained that can help people achieve true tolerance and long-term tolerance through OIT. With SLIT, initially that one is one where you're not free eating the food, but it's going to protect against some accidental exposures and kind of protect against cross contaminants, accidentals. If you do slit long enough, maybe 4 or 5 years, eventually you might get to the point of tolerance. There's some data that there was a really great study that showed at 48 months of doing slit, um, I think there was like 30 to 35% of patients could tolerate 5 grams of that protein. That's a big dose. Um, so about a third of the patients that even just doing slit for 4 years was able to, tolerate 5 grams of the protein. So eventually you may get there. But the aim of slit really is that cross-contaminant and that protection. With OIT, absolutely you can get there. And but OIT kind of took off to start with because of that concept of we can free eat. But what we found through doing this over the last decade is not everyone wants that. And that was kind of initially our own assumption. But once we've treated hundreds and thousands of patients, some of them don't like the food. They don't want the food. They have such taste aversion to it that it's like they just want safety from it. That's okay. And my approach is I want to meet somebody where they are, guide them to where they want to go, and initially, to your point, they may not know where they want to go. They may just think, I just want safety. Okay, let's start there. Let's start with safety. And then once we get going in the process and we start going, it's like, well, now let's tailor this and individualize it as you define more what you want. And we can always tailor that therapy to it. Part of the problem has been, and this happens in large academic centers or people that are new to treating, they are so focused on products and protocols. That's all they care about is like, oh, we want to put everyone in the same protocol. I think that's a mistake, because they're trying to find a one size fits all for patients. I want to find the size that fits the one. And that's what I want to do is find out, okay, I'm fluent in all forms of food allergy treatment. So it's like, okay, let's understand the pros and the cons of each of these. And then let's figure out where the patient wants to start, where they want to go. Let's offer that. And if we need to pivot at some point and adjust, then let's do that because we can. And it offers them choice. And that way the patient also has more of a say in the matter. Plus, we can tailor that therapy according to their needs and according to what they want, not trying to, pigeonhole everyone into just one set protocol.
In Australia, it's obviously a very new concept, even though, America has been doing it for over a decade, Croatia, post-war country for 9 years in the public system, Singapore and many other countries. But what we found in the sort of patient communities in Australia is a lot of allergists start with real food in that solid form, and a lot of patients around Australia report severe reactions. Um, what would you say to doctors who don't have that knowledge or who want to trial it themselves in a way? Where should they start?
Can I speak candid about Australia?
Of course, this is a very open, candid podcast.
So this is not I'm going to correct one thing. This is not a new concept to the allergists in Australia. They've known about it for a decade and a half because I spoke to them. And some of them actually came to a presentation that I gave in Melbourne back in, I think it was like 2017, 2018. Um, they've known. Uh, the problem is it's been suppressed from my perspective because I actually wanted to collaborate with many, many allergists over the years and they simply wouldn't. Or they would try and steal what I was doing. And then all of a sudden they're trying to recreate or reinvent electricity. It's like, well, we've already done these studies, but for some reason it was ignored to do their own. And in the process, suppressing treatment from being introduced into the country for many, many years, which I think is a disservice to the patients. Um, and now what I'm seeing is many that are starting or doing it, as I'm seeing some of these patients or hearing about their cases, um, I don't understand because they're really not using protocols that are tried and true. They're doing things that I don't really understand why they're doing it. And what I would suggest is I have had over the last couple of years a great collaboration with other allergists from different parts of the world. England, for instance. Um, I presented at a congress in Jordan, in the Middle East. Um, have collaborated with many doctors in Europe. They're very open to our collaboration. And I think Australia just needs to do that. Like, be more open to the collaboration, be more open to working with each other. This isn't a us versus them. This is us collectively against the allergies. And why not put our heads together and just work together, acknowledge the science that's there, stop trying to reinvent a peanut product that has already been on the market in the US when we've actually shown you don't need those. You can actually use real food and you can champion this. I mean, with our fast OIT data, um, there's an FDA approved peanut product, peanut capsule in the US, and less than 5% of the patients treated in the United States are being treated with that product. 95 plus percent are just being treated with real food. And the products are there, the protocols are there. It's not hard to find, it's published. But like I said before, the product and the protocol are just one aspect of this. What really needs to happen is they should come to fast. They should, collaborate. Our arms have been open, welcomed. I've tried. I have tried to collaborate with them for so many years, um, and just haven't been met very kindly. And I would love to be able to open that up to where there's a lot more collaboration, professionalism amongst us. And I think there could be tremendous opportunities there.
Just to remind our listeners that probably are not everyone is aware, over 50 Australian families over the last 11 years moved to Utah to access Dr. Jones's programs, to actually live in Utah, and they were actually very much welcomed by the people of Utah. And this resulted in the governor of Utah giving an acknowledgement publicly to Dr. Jones and with one Australian family at the time who was there for all this effort that was done over the years. And with your former Australian patients, you have 11 years of data. Nobody in the world has 11 years of data for Australians doing OIT. What happens to them 11 years later? What did you see?
Oh, it's been amazing. I mean, we were able to go back and I spoke at, Food Allergy Expo a year or two ago, and I was able to meet with had a reunion with several of our patients that we had treated, almost a decade ago, and they are thriving. They're absolutely thriving, and just so thankful that they didn't have to live the life of fear and anxiety for that previous decade, where they're pursuing dreams and goals and jobs and higher education and all these things that they would have been scared to do before. And so 10 years later, they are just thriving and just thankful that yes, it was a massive investment for them to do it, but uh, so thankful that they did and are. And it's great that we were able to co-found Immunity Group Australia because now people don't have to make that journey if they don't want to. You know, they can have that opportunity locally through the doctors that I've trained, utilizing, you know, our system, and it's awesome.
I love the fact that the innovation and R&D which you brought into Australia through Immunity Group Australia is actually at the forefront of educating doctors who see patients with allergy first. We're not talking about emergent care, we're talking about general practitioners. And in England, Professor Fox and his team also have been at the forefront of educating general practitioners, with some of them themselves actually becoming innovators in the food allergy space, like Dr. Helen, you know, with their own protocols and having tremendous success. In America, in terms of the general practitioners level of knowledge with allergies, is that a target group for your community in terms of education about treatments and options and opportunities?
Sorry, which group?
General practitioners, those are the general
Uh,
places that patients go
not,
first.
yeah, in the United States, not currently, just because we do have more allergists that are on board with this. We have kind of broken through the suppression from our, you know, academies because they were doing the same thing that the Australian societies were doing, was trying to suppress this for a while. And we've been able to break through that, and through our fast network, um, it's becoming more and more available. So that's really kind of been our focus currently. Uh, you know, in other areas of the world, we've had to take a different approach just so that patients could get treatment. But again, it's trying to be resourceful with the hand we're dealt in each country and each place.
It's a true global effort.
Yeah.
One of the most amazing things I think from your approach, which you emphasize in all your talks, is the gut health component. Not many allergists understand, especially in Australia, they never mention the gut health. They do mention skin health often with eczema, you know, the whole control your eczema if you want a better outcome in terms of everything else. But why is gut microbiome important when addressing food allergies? What does our nutrition do to us? Even if we eat allergy-safe foods that can aggravate or maybe even contribute to the creation of new allergies.
Great question. And it's something that I've kind of taken a deep dive in over the last several years. I think it's critical, and I also think it's something that separates our program from others because we do take a more integrative and holistic approach to patients. I don't just see it as just a food allergy. I mean, I'm looking at their whole health, thinking about their anxiety surrounding it, their stressors, their environmental inputs, and to your point, looking at their gut microbiome and their gut health, because one of the most common side effects of OIT is upset stomachs and vomiting or gut inflammation. And a lot of people will just try to treat that perhaps with an antacid, um, you know, different measures, but to me, that's not really getting at the root cause. Part of the reason so many people have had um, that common side effect is because of poor gut health. And when you fix that, the percentage of those side effects and the percentage of those issues plummets. Doesn't mean it eliminates all of it, you know, because sometimes we have to deal with that food that they're now ingesting through the program as being inflammatory and altering things. But the percentages just really work in our favor when we can address the gut microbiome. And part of what goes into that is stress and sleep and exercise and adequate nutrition. One of the things that makes me cringe is sometimes when people do OIT, you don't want to take it on an empty stomach. Your stomach doesn't have to be full, but you don't want to take it on an empty stomach. But often the snacks that are recommended are terrible for the gut health. There's full of processed sugars and simple carbs and those types of things. And I'm like, no, because you're actually feeding, fueling the fire and potentially even creating more side effects. And it's like what we want to do is encourage healthier nutrition, healthier snacks, um, things that would promote a healthier microbiome and less inflammation than some of the other things that I've seen recommended.
And in your first book, which was published in Australia actually a couple of years ago, the Immune Fitness Project and how to improve food allergy resilience, you do talk about the importance of vitamin D. And
Mhm.
most people don't know that vitamin D is not vitamin at all. So, what is vitamin D? How does it affect immunity? And can it contribute or not to the success of OIT?
Yes, and I'll say this very confidently, but I'll tell you a lot of my colleagues still don't believe me on this and don't pay attention to it. Vitamin D is very poorly named. It is more in the class of a steroid hormone in our body. And steroids, as you know, natural steroids, but as you know, they're anti-inflammatory. So vitamin D has several roles. Like it would act as more of a natural anti-inflammatory. It stabilizes a cell called a mast cell. And the reason that's important is mast cells contain all the chemicals that are released in an allergic reaction. So if that cell is unstable, that means it's more likely to open up and release those chemicals. Whereas if that cell is more stable, you change that threshold by which that cell opens up. So we're not only reducing inflammation, but we're also stabilizing those cells and giving it a little bit better chance of not reacting. We see a lot of patients, for instance, with recurring hives, and they may be not food related or environmental related or this or that. And it's crazy because so many times vitamin D is never even thought about or looked at, and they're just treated with antihistamines and Xolair and all these medications. When a lot of times you look at the vitamin D and adequately correct it, a lot of times those hives just go away. Why? Because you're reducing inflammation and stabilizing those mast cells. Um, it helps with frontline defenses against viruses, which is again kind of another layer of if you're looking at risk or reactions to OIT, viruses and infections are a risk. And so if you can minimize that, minimize the number of viruses, minimize the inflammation, stabilize those cells, patients tend to do better. Part of the reason I think this has been largely ignored by the medical community, especially my specialty, is when they look at data, they'll say, well, giving vitamin D doesn't make any difference. Well, when you look at those studies that they're referencing, though, a lot of times they are looking at bone health and like density and fractures. They're not taking into account actually what's happening on the immune side. And when you look at a reference range, years and years and years ago, those reference ranges for normal, quote unquote, normal were set by what's the minimum amount of vitamin D somebody needs to prevent rickets. That was it. What's the minimum amount? And that's what they looked at, and that's how they defined normal. That hasn't changed for decades. And granted, years ago, that's what we thought the role of vitamin D was. But since then, we have 2+ decades of data on the beneficial role of vitamin D, but you do need higher levels to make the difference. And so you kind of have what's the minimum amount to prevent rickets and also bone health. But what I would argue is what's the minimum amount to make a substantial difference in the immune system. So you have to run it just a little bit higher. Um, and so the studies aren't going to be conclusive. They're not going to give you the answer you want because they're asking the wrong questions. And
That's a lots of studies will go around in circles.
yeah, they go in circles. So that's kind of my personal experience with it. You can take a deep dive into literature outside of allergy immunology. Thankfully, we have colleagues in other specialties that are very, very well aware of this.
Amazing. And you mentioned the stabilization of mast cells. And the question we had from a lot of our community members is how do environmental triggers affect OIT and what can people do about it?
Yeah, environmental triggers can play a big role because if you have those exposures, again, you're increasing inflammation, you're increasing the activity of the immune system, and those mast cells are going to be opening up. And we call it degranulation. That's the term that we use when it opens up and releases the chemicals. Um, that's going to be happening. Let's say, for instance, you have a cat allergy and the cat's in the house and you have that persistent trigger. Well, your mast cells are going to be opening up. They're going to be degranulating. They're going to be releasing these chemicals acutely, but also chronically. And so you get more inflamed, which is where, some people may get asthma, some people may have more struggles with eczema. And so it kind of feeds on itself.
So
And
it's
what to do about it, the last part of your question is get good control of it. If you can do immunotherapy to those things, even better, because now you're not just treating symptoms, but you're treating more root cause.
great, great answer. When it comes to biologics, people are talking now about not just Xolair, but the latest asthma drug trial, which showed some promising results for food allergies as well. What's your take on that? You've been dealing with these asthma medications as an allergist and asthma specialist for over a decade. Why do we see all this asthma medication now being flagged as beneficial for possibly managing food allergies in the future?
Yeah, so omalizumab is the generic, or Xolair is the trade name for it. Yeah, we've been giving that for over 20 some years for asthma. The next indication that it got from the FDA was for chronic urticaria or chronic hives. And then recently it was FDA approved for food allergies. And as I alluded to at the beginning of the conversation, it doesn't change the immune system. What it does is it is called a monoclonal antibody. So it is an antibody. And within the immune system, there is an antibody, a different kind called IgE. Uh, that's what it's abbreviated as. IgE kind of it can coat the mast cell and it just docks onto it and it sits there and it waits. And the IgE can be very specific to what you're allergic to. It's like a lock-in key mechanism. So it's the lock and it's just waiting for the key to attach to it and open it up. So let's say you're allergic to cashews. You'll make IgE that's very specific for cashews, and that IgE can then coat the mast cell. It sits there at the end of it's like a lock, and it's waiting for the key, which is the cashew protein, to come in. When you have the exposure, that cashew key comes in, it'll bind onto those IgEs, sends a signal, to open up, and it releases all the chemicals. Okay. That's the basis of just very basic allergic reaction. What Xolair does is it binds to IgE, preventing it from docking onto the mast cell. So if it's not able to dock onto the mast cell, even if you have exposure to that certain food or allergen, nothing happens.
They're
Uh,
jamming the key, pretty much.
yes, yeah, very good. Yeah, you're basically taking the lock off the door.
Okay.
Is what you're doing. What you know, you're taking the lock off the door. If the lock's off the door and it's just closed, there's nothing to go in and open it up. It's just closed, and all your allergy chemicals stay in the house.
Yep. So
So
amazing in
so
terms of
yeah, that's
short
what's
term.
happening. Now, does it happen? Why would some people still have reactions occasionally? Well, because it's not a perfect process, right? So you may not mop all of it up, you may not take all the locks off, and so you have percentages there, but it does work really well. But what they found is like it does the reason you're seeing all the news now is because it had FDA approval for food allergies in the United States. Um, but again, it's not changing the immune system. Like the immune system is still making the cashew IgEs, it's still making the cat IgEs or all the specific things. It's still making all of those things. So you have to keep giving it to maintain the locks off the doors. Um, because you're not altering any of the underlying problems.
What
We
happens
have
after Zolair? Like what happens when if people just stop Zolair 2 years later?
everything comes back. Everything's still there.
Wow.
Because it doesn't change the immune systems. It now the only thing that changes that is if you do immunotherapy in conjunction with that, which we've done successfully for 10 years. So the FDA approval in the United States is not to be used in conjunction with OIT. It's just to be used as an injection to try and raise the threshold by which somebody's going to react, if they have an exposure. Um, Off-label usage would be in conjunction with OIT. The beauty of that is it does enhance safety and you can do it quicker. Um, but doing it in conjunction with OIT is nice because now you're actually changing the immune system, not just taking the doors off. You're actually, stopping the production of that specific IgE.
What a beautiful ex explanation, I guess, for everyone who is following the news and yeah, talking about Zolair and trying to possibly get hold of it, which is not easy.
So it's nice. It has a nice niche, or niche for certain patients. I don't think it's necessarily for everyone, and not everyone can do it. But for those that can, we can use it effectively in certain situations.
I also want to mention to our audience that there will be very exciting summit is coming up, and you will be coming from the US for this summit. Can you tell me more about it so that our audience can hear from you?
Yeah, I am really excited. So the end of October, I'll be coming to Australia, and we're gonna have a summit with um, you and two of our colleagues, Emma Sutherland and Sharon Selby, and we're going to each take a unique approach to food allergy. And it's going to be not only talking more in depth about our protocols and kind of our process for treating food allergies, but they are also experts in an integrative approach and also gut health. And we'll also kind of blend in the parent perspective from that. So it's going to be a really nice, balanced summit where we can approach this from many different angles. And I'm excited to have them on board because they're going to be talking about things that we do and that we incorporate into our treatment program. And, they are well known, well respected people in Australia. So I'm just honored to be doing this with them and you.
I'm very excited as well. We'll have a very nice program for everyone. But apart from this summit, I just want to ask you one last question. From a scientific and personal standpoint, what keeps you curious and motivated in your work going forward?
Patience. My motivation is always to serve the patient more and fine tune what we're doing. So many times, 10, 12 years ago when we were starting OIT, it's funny because the opponents were like, well, it's not a cure. It's not a cure. It's not perfect. And people have reactions like, right, but you don't like withhold treatment while you're perfecting the treatment. It's not like, oh, if somebody has cancer or diabetes, for instance, it's like, well, sorry, insulin's not a cure, so do we just withhold it? No, you treat it. Are there pros and cons to it? Absolutely. But you don't withhold it. Or if somebody has cancer and they've had to have a chemotherapy that has certain side effects to it, do you withhold that? No. You offer it. And guess what? As you go along, you get better and better and better. And you fine tune and you make it better for the patient. Because I often think about burden of disease and burden of treatment. And what we want to do is reduce both. We want to reduce the burden of disease, and we also want to reduce the burden of our treatment options. But we wouldn't have been able to get where we are today had we not just taken that leap 10, 12 years ago and had, the courage to do it because we have learned so much. And the beautiful thing getting back to fast is, it, you know, what, 9 years ago when we started this, there was, I think, 30 people in attendance. Um, Now there's over 200. But we have all grown together in this because we were willing to collaborate, we were willing to share, we were willing to learn from each other and have that open dialogue. Um, and we have been able to evolve and pivot and just fine tune what we're doing, and we'll continue to do so. And that motivates me because I want to find, those answers for the patients. And if there's more that we can do on the microbiome, if there's more that we can do with their mental and emotional health, if there's more that we can do all across the board, uh, we want to continue to make this better so that we're reducing that burden of treatment and then easing that burden of disease.
What a wonderful answer. Dr. Doug Jones, thank you for being with us today and for sharing your insights, knowledge, and enthusiasm, which is clear and has come out so beautifully. Thank you for being here with us.
Thank you.